All right, part B of Learning Plan 10, we're going to be talking about opioid and analgesics. Three types of opioids: agonist, agonist-antagonist, or partial agonist, and antagonist. They're categorize that based on their function, and we'll talk about each of those in order. Opioid analgesics. These are pain relievers, sometimes called painkillers, that contain opium, which is derived from the opium poppy or is chemically related to opium. These are very strong pain relievers. They're used to alleviate moderate to severe pain. And of course, moderate to severe depends on the route. Oral opioids will be more for the moderate, whereas the IV will be more for severe. They can also be used for cough center suppression and the treatment of diarrhea because they can cause constipation, especially when used for long term. A couple of doses, probably not, but chronic will almost certainly cause constipation. They bind to receptors on those inhibitory fibers, which stimulates them. They prevent stimulation of the gate. Right? They shut the gate. And they prevent the pain impulse transmission to the brain. So the pain hasn't gone away. It still hurts. You just don't know it. And I guess in that regard, if you don't know it, it's not there. Oh, well, it really is, but you know what I mean. Now, a couple things. If we're looking at something that powerful, you are not going to want to. You're going to make sure your patient does not drink alcohol or operate heavy machinery, even driving a car, driving a lawnmower, whatever. These are powerful medications. They can affect your level of consciousness quite greatly. If you add alcohol or other medications like benzodiazepines, you can rapidly develop many adverse side effects. So of the opioid analgesics, these are all Schedule II medications. Schedule II, remember what Schedule II means? High risk for abuse and misuse and addiction. So these are Schedule II. And maybe some of you have had these medications. If a doctor writes you a prescription for one of these medications, he cannot or she cannot call it to the pharmacy. You have to go there with a paper prescription in hand and pick it up. You may have to sign some documents and show some ID. They're very careful with opioid analgesics. The risk of misuse is very high. As I mentioned earlier, morphine is considered like the gold standard of opioid analgesics. It's been around a long time. It works very well. And it can be given IV, IM, PO, sublingual. I think that's it. Codeine sulfate, Tylenol 3. That is an opioid, but that would go for the more moderate pain. Hydromorphone, very powerful. We're going to talk about the comparison of these in a couple slides. Fentanyl, meperidine is the generic name for Demerol, which is another Schedule II drug. That used to be used a lot more than it is now, but it still is in use. Oxycodone, Percocet, Percodan, depends on what oxycodone is mixed with. If it's oxycodone and acetaminophen, it's Percocet. Oxycodone and aspirin is Percodan. Oxycodone plain is just oxycodone. And then, of course, Vicodin, which is hydrocodone with acetaminophen. Now, there's a lot of drugs that have similar names. Do not confuse morphine with hydromorphone. Very different. Well, very similar, but one is much more powerful. Percocet versus Percodan. Oxycodone versus the brand name OxyContin. Oxycodone is immediate release. OxyContin is a sustained release which lasts up to 12 hours. If you confuse the two, you either will be giving not the correct pain relief or too much pain relief. So always be careful with the medications you're using and make sure you use the correct one. Transdermal, fentanyl. Fentanyl is commonly given IV, but can also be given transdermally through a patch. And of course, we're going to wear gloves when we handle these patches. So why would we use a patch? Well, this is not going to be for acute pain. This will be for pain for people who have been on opioids for a while, and a lot of it. As the slide says here, for people who have been taking daily for a week or longer, at least 60 milligrams of morphine, 30 milligrams of oral oxycodone, or 8 milligrams of oral hydromorphone. That's a lot of painkillers. So if a person's been doing that for more than a week, a transdermal patch might be the correct way of doing this. Now, why would this be so much better? Well, I'm sure you all can figure that out. Giving IV, you get boom, pain relief, boom, pain relief, boom. Transdermal, you apply it and it just slowly and steadily absorbs into the skin. So you have continuous pain relief. You don't need as much at any given time because you're always getting it. Much like when we talked about the insulin pump, always putting out a little bit of insulin, giving you better level control. Now we have opioid antagonist agonists. These have much less misuse potential and addiction liability. They're lower because they're not pure agonist opioids. The antagonist activity actually can produce withdrawal symptoms of opioids for some people who have been using opioids. Nubane, nalbuphine, pentazocine, and butorphanol are the three most common generic names for opioid antagonist-agonist. And then we have opioid antagonist. Now, remember, like morphine is an agonist. It takes an effect. Opiate antagonists prevent. These actually compete with and reverse the effect of opioids. They bind to those opiate receptors and actually prevent an opioid response. They're used for complete or partial reversal of opioid-induced respiratory or CNS depression. It can work very fast. You give 0.4 milligrams to 2 milligrams IV every 2 to 3 minutes until you achieve the reversal level that you need. Half-life of 64 minutes. So remember, if a person's been using a lot of opioids and you're able to reverse it with Narcan, or naloxone is the generic, watch. You know, in an hour or so, you might have that opioid come back. So continually assess respiratory status, CNS, level of consciousness. This will work for any opiate. So morphine, Vicodin, meperidine, as I mentioned, oxycodone. This will reverse opiates. So which route is best? You know, we have oral, we have IV, IM, transdermal, regional like an epidural or spinal. So which route is best? It depends on what we're trying to do. And it depends on how bad the pain is. If the pain isn't very bad, oral is fine, especially if you can take it on a relatively regular basis. Pain horrible? Maybe IV. Chronic, long-term, transdermal. Very specific to a specific spot, maybe a regional block, an epidural, a spinal block. It always depends on what you're trying to do and where the pain's located and how bad the pain is. So I mentioned we were going to talk about the equa analgesic table. Here's a table that actually compares morphine. Morphine is considered the comparison for everything else. And it shows you how much of another medication you have for the same dose or same effect as morphine. So if a person's taking 10 milligrams of morphine, oral IV, they would need 75 milligrams of meperidine, but only 1.5 milligrams of hydromorphone, and 0.1 milligram of fentanyl. 0.1 milligram of fentanyl is equivalent to 10 milligrams of morphine. That's power. But we have to look at duration too. Fentanyl has a duration of 1 to 2 hours. Morphine will last 4 to 6 hours. So we're always considering how bad is the pain, where is it located, how long have you had it, and how long does it last. And that'll help us determine how we're going to treat it. When you're doing an equal analgesic calculation, you look at for a situation here, your person's on a morphine PCA pump and they're able to take oral medications like Tylox, which is another brand name of Percocet. They've used 24 milligrams of morphine over the past 24 hours. How much Percocet will we need? Well, there's a calculation here, and we'll do this in class. We will do some calculation in class on how to determine how much oxycodone is needed for the same level of control. Now, there are a lot of side effects when you use opioids. The biggest is going to be respiratory depression. Will we see that in everybody? No, we won't. But we have to watch for it all the time. Respiratory depression, if a person is sleepy and you notice that they're breathing much less than 12, 10, or 8, wake them up. Make sure that it's just sleeping and it's not an excessive opioid effect. I also mentioned constipation. If a person's on long-term narcotics, long-term opioids, constipation is very common. So what are we going to do? We're going to encourage fluids. We're going to encourage activity as much as possible. Encourage fiber in their diet. We're going to watch for CNS depression and hypotension and nausea and vomiting. We have a lot of side effects we need to watch out for. All of these can be life-threatening or life-altering. If you get itching and rash and hives, obviously that can be life-threatening. Constipated can be life-misering. So, opioid analgesics, what happens? What's the difference between pain management versus the risk of addiction? What happens when the patient says, you know, I've been needing more and more for the same relief? Are they dependent? Are they addicted? They're tolerant. Narcotic tolerance happens over time. It's a common physiological result of chronic opioid treatment. Larger and larger amounts of the opioid medications are required to maintain the same level of analgesia. So that's tolerance. It happens. It does not mean they're addicted. It does not mean they're dependent. It means that their body just needs more. Physical dependent is a physiological adaptation of the body to the presence of the opioid. Here, your body chemistry is changing so that it needs that opioid. That is different than tolerance. When you stop, if a person is that level and they quickly stop, you get withdrawal symptoms. Anxiety, irritability, chills and hot flashes, joint pain, everything you can think of, along with nausea, vomiting, and diarrhea, like everything else. Now, there's also psychological dependence. We just talked about physical dependence. Psychological dependence, it's a pattern of compulsive drug use characterized by continued craving of an opioid and the need to use it for the opioid effects, not pain relief. Opioid intolerance and physical dependence are expected with long-term use. They really are. That's not the same as psychological dependence. Psychological dependence is addiction. When you're working with fentanyl patches, and you may in a hospital or nursing home, they're used for 3 days at a time and then they're taken off and replaced. Make sure you take off the old one before you put the new one on, and then you'll sign and date or initial and date the new one. When you take the old one off, fold it together because it's still sticky and there's still active ingredients in there, and then flush it down the toilet unless your facility has a different, more secure method of getting rid of those patches. Those patches can be stolen and reused by other people. So we will fold them together, flush them, unless your facility has a specific policy on how to dispose of patches. All right, come back for the next section. We're going to talk about non-opioid analgesics.